R-A.
100.
Sram.
100.
So, how was it? All well? Any problems?
No problems.
8 days?
Yeah, went
So no nausea, no vomiting?
no nausea, no vomiting.
So what was your perception earlier before getting the surgery done? Because you have been in US and you are in healthcare.
Yeah.
You must have
Coming
seen
here
coming
the
here
surgery.
for the surgery.
I had a good perception. I was very positive because my mom had it done like for 2 months almost. And we had a couple of other family members also
who got it done from here?
Yeah.
Okay.
So, and your customer service, all your staff, everybody, like
You like it?
housekeeping,
So-
kitchen, everybody's like wonderful.
This is
Definitely
totally
this
different.
surgery by
Yes.
far. I mean, I've studied all of the other surgeries before I decided to do this. Like this is much better. Like at least it can gives you that cushion, like that vacuum that you cannot eat and stuff like that. That's not
That's
there.
not
Like
there,
you can
yeah.
still try different.
So there is some luxury.
Yeah,
you know.
definitely.
First of all, there is safety.
Yeah.
You went through the surgery and you see, I mean, it's like even less than a C-section.
Yeah, like true. Like I was up like after 2 hours of surgery, I was awake and I
So
was.
what else we want for such heavy patients if they can be out of bed within 2 hours and then you are walking and then on day 2 you are taking semi-solids.
Yeah.
Where, I mean, if we compare it with other old restrictive techniques like sleeve or band or even the Roux-en-Y, where the pouch used to be 30 cc and the outlet was very tight. And this is, you know.
And biggest thing I've seen the difference because I have treated those patients myself with the bariatric sleeve and bariatric surgery. The risk of infection is way less than comparing to those and the.
Okay. So you saw those patients, what kind of infections they were having?
Well, some people just got, two patients, one died because of being septic and the other one had a lot of complications. She was back and forth in the hospital and a rehab center. But one definitely, like, she died.
Yeah, actually things are changing now and from last about 18 years, you can see it has been a big revolution in bariatric surgery because primarily what our aim is, number one is safety. Weight loss is okay, it should be there, but safety is like something so prime that we cannot, there's no trade-off. I mean, safety, we need it at any cost. So, safety-wise, mini gastric bypass is way better than other old techniques because, number one, it takes 20 minutes. Now our team is trained, so less anesthesia.
I thought it was like 5 minutes I was in and out.
Yeah. And that's why you're out of bed within 2 hours. Because if we give less anesthesia, then you are out of the anesthesia faster. And these are all heavy patients. You need to give them high dosages of anesthesia. And if you're keeping them knocked out for 2 hours, 3 hours for surgery, then obviously it's going to take a lot of time to get out of their blood. So if we the prolonged surgery and prolonged anesthesia means infection and complications.
True.
Infection is going to come from, if we spend more time with the patient inside the OR.
More time your body is open
Yes.
to the outside.
Body is open to the outside and everybody inside the operation theater is breathing, Bacteria are always there in the air. So we want to get into your body and come out as fast as possible.
No, definitely. I'm very happy. I mean, I feel good and I'm ready
So
to
then
go back
this
to
is
work.
number one. Number two big difference is the low pressure system. This surgery, why it doesn't give you nausea, vomiting, and why it gives you some luxury to eat, because it is a low pressure system. Now it has been established. Why low pressure? Because at the outlet of the stomach, which we have designed now for you, at the outlet of the stomach, there is no obstructive thing, no bend, no pylorus. Like in sleeve, you have pylorus at the outlet. In MGB, our mechanism of weight loss is altogether different. We do not believe in mechanical obstruction on the way to the food because that makes the patient unhappy. You want to eat, but it's stuck up here. We don't want to see that because that is what's going to make you unhappy, and then you'll try to take something which goes down easily. And then sort of pops, ice cream, candies, all those things, and then we say that you have to change your lifestyle after the surgery.
Well, even now, I mean, it's only like 8 days, right? Like I still have some swelling inside and it's still healing inside. So even now, like I'll take a couple of bites, I have to walk, sit down, eat, and then walk again, sit
So,
down.
so it is not that restriction is not there.
No,
The
I mean I
amount
can
of
eat,
food
but I
which you
just
can
have
eat.
to kind of work it out.
Yes, yes. So restriction is there without a band, without a sleeve.
No,
How is
true.
it coming? Although the outlet is big, 6 centimeters, and that gives you the luxury to start eating quickly after surgery. Why you have restriction? Because your food is actually now just being delivered to the jejunum.
True.
Now your jejunum is
That
your
is
reservoir,
smaller now.
and the jejunum in itself is like a tube, and although it's flexible, it can adjust some amount, but once it dilates, then it gives signals to your brain that you're done, and then you don't want to eat more.
Yeah, I know,
So-
definitely you kind of, I just like, that's what my experience is, like for
Uh-huh.
last 8 days.
Mhm.
Well, I would say 7 because, you know,
Yeah.
I didn't eat.
Mhm.
It's like I take couple of bites, I walk, couple of feet, like steps, and then I come back, then I have to eat a little bit more.
Yeah.
And I've tried eating like all together,
Uh-huh.
and after that I know I was like
Yeah.
feeling discomfort,
Yeah.
so then I still had to walk.
So a restriction without mechanical obstruction. This is the main difference in MGB and the old techniques. That's why we say that it's a kind of revolution, because the big outlet, if the food is not getting obstructed, so there's less back pressure, less chances of leak, less chance of nausea, vomiting, and you're back to normal diet as quickly as possible. And in the long run as well, we are seeing, we are comparing our other patients by giving, contrast to them to eat, and then we take the X-ray and see how much the pouch has dilated
Dilated.
after 1 year, 2 years, 5
Do
years,
you
8
expect
years.
it to be dilating or?
We have to expect everything, we,
No, but
at
what
least
is
we need
your-
to, but that's what I have, I have understood within these 9 years of my practice, that because of the big outlet, mini gastric bypass dilates the least.
Okay.
And those procedures which have got the tight outlets, like I have been doing a lot of sleeves earlier, and all the young girls like you, I would do a sleeve in the beginning when I started my practice, because I was even slightly skeptical about mini gastric bypass, and it was my belief that why do we give malabsorption to the patient? So it's better to just work on restriction only. So if you don't eat much, you will lose weight. But the irony of the situation was that many of the patients did not lose the adequate amount of weight. So then, what now we understand from this is that if you are a high volume eater, if before surgery you were eating this much, then if I give you a restrictive technique, it would work. And that's what we see in sleep
Are you
patients.
seeing in like a lot of patients?
Yeah, and sleep patients, I see some patients, they behave really well. So they come down from 150 kilos to 80 kilos. But now I know that what's the difference. They were eating big volumes of food before surgery, and after surgery the difference is that they are not eating big volumes, because we have made the stomach tighter and a tube-like stomach. That's what is sleep. So what about those patients who are not taking big volumes before surgery?
Bija?
Yes. Then if I do a sleeve on you, not going to work. Because what is it going to do inside your body? You were already not taking too much.
I was already eating only 1 meal a day,
Yeah.
pretty much, and couple
So
of.
the low volume eaters, how much further tighter I can make.
Yeah.
And if I make you too tight, then nausea, vomiting, and depression, all those things are going to come up. And if somebody can take a moderate amount of food, if you have taken, say, even half a burger or some normal Indian diet like sabzi or dal or half chapati, and you are done, then over that you would not like to have Coke or other soda pops or anything, because you are satisfied.
Mhm.
But if I make you so tight that you cannot eat anything, if the pouch is so little that you can just drink, then you will try to, your brain will be always
So-
craving for something, and it's a kind of fight between the brain and this procedure, and then ultimately you will try some liquid, sweet things like ice cream or sodas or something like that, which goes down easily, pudding, and that's going to give you a lot of calories. At the same time, you are not taking healthy food. So that is the reason why such girls like you, if I did sleeve on them, and if they were low volume eaters, they don't show results, because there's nothing which we have done. They were already taking low volumes, and even after surgery, although they are still taking lower volumes, but they are taking more of soft calories. So the total amount of intake is the same. But with MGB, another difference is that your habits are going to change. Now, if you take one bowl of ice cream, it will do well. But if you take 3 or 4 bowls of ice cream in one go, you can try this today. It's not going to stop you because the outlet is big, you can take. But everything is being delivered to the jejunum, and jejunum will become full with ice cream, and then it's going to assess the amount of sugar which has entered your body, and that kind of signal is going to deliver to the pancreas. It's going to order the pancreas that a lot of sugar has come today, which it has never seen earlier. So what's going to happen? High insulin. Immediately after that, within 15-20 minutes, pancreas is going to produce insulin. It's like a sudden kick to the pancreas, and in return, your sugar will go down, and your pulses will go fast. You will start sweating, having palpitations, and this is called as dumping.
Dumping syndrome.
Yes. This is kind of blessing disguise with the MGB because of the wide outlet. Gastric emptying is fast. Everything is going down into the jejunum, and it sends strong signals. If you're eating any wrong food, it's going to send a strong signal to the pancreas, and it's going to stop you, but not right away. After 15-20 minutes.
Yeah, true.
That's why I tell my patients to maintain a food diary and see how your tummy is behaving. So with that, you will start developing a kind of hatred towards certain foods. And if I take 2 cups of ice cream, I will not feel well after 15
I think I'm
20
already
minutes.
hating cha
Yes.
and coffee.
Yes, that's what
Which
I
was like
see
my
in most of
favorite.
the patients. And this is a kind of drastic change in their eating behavior which comes with MGB because of some subclinical dumping, which I feel is a must, because either you don't like something or you don't take something. There are 2 things which you can choose. But not taking something is not possible because your brain wants it. But if you're not liking something, after like a month or so, if you start hating these kind of foods, and this hatred might even work for lifelong. If once you start hating something, you don't try to take it again.
And I have another question, like for my particular case, my surgery, what you did and whatever size you have, how many calories per day are you suggesting me to eat?
See, we cannot calculate the calories. You can do that for a couple of months. The diet charts have not worked, and we know that you cannot control your brain. So whatever your body demands, you can take. Just you should have the knowledge that this surgery is strong, and it's going to take out 1% out from your body. You need proteins. Only focus on proteins. Do not count the calories, because the calories are controlled by the brain, not by.
So less carbs, more protein.
Yes. Less. You won't like
Carbs.
I don't have to tell my patients what to take.
Well,
I'll say,
I try to eat
try
roti.
everything. You
Like, I
can
want
try
to eat
rice
roti.
today. You can try roti today.
I
Some bread.
ate roti already.
You already.
Yesterday.
Okay. How much
and
you could take? Half or one?
No, actually I ate one roti. But
One
then
roti.
after that I was like very uncomfortable for like a
Okay.
couple of hours. And then I ate a little bit of rice this morning.
Okay. So you digested that.
Yeah,
well?
that was fine.
Okay. So this is what you need to notice. Just keep on noting what you ate and how it behaved,
Yeah.
so that you should know what is hurting you and what is helping you. And within 2 months, you will come to know that if I take fruits, raw vegetables, and a food with less oil, it suits your tummy. A food which is oily, or more of breads or chapatis or rotis, after 15-20 minutes, the feeling your abdomen is going to give you is not very good. So that's what you need to, differentiate
Yeah,
which
eating
food your
protein
body is
should
like.
not be a problem.
Proteins, the best would be chicken and fish,
Eggs.
and eggs and milk, and curd is something very good.
Yeah.
You should use curd as frequently as possible. Then vitamins we are going to start today. And the most common deficiency which we are noticing in young girls is iron deficiency. So you should take iron tablet religiously, and anytime you feel you are having less energy, that means your iron might have gone low.
Okay, yeah, well,
Because on one hand they are menstruating and losing weight, so all the young girls should understand that with any kind of bariatric surgery they can have a low iron because you're losing weight. And after 45 we don't see low iron that frequently. So you must take iron and multivitamin and calcium, and then go out and in the sun and do some workout as well. Yeah, vitamin D comes only from the sun,
Yeah.
not from tablets.
Not by taking tablets.
So you need to go out and do some workout so that your bones demand calcium.
Yeah.
If the bones demand calcium, only then they are going to fetch it from the blood, right?
Okay, and I need list of blood work that I need to do over there. so I
Yes,
can
that's
get-
mentioned
and-
here in the discharge card.